Okay, good afternoon. Can everybody hear me?
Yep. Good
Okay,
afternoon,
that's
Ben.
great. Good afternoon, everyone, and a very, very warm welcome to everyone joining us in this very special session of the webinar today. I am Dr. Vancy Kwok, and I'm from Hong Kong, and it is my genuine pleasure to be your host today for the Pediatric Pain Special Interest Group series focusing on pain in children with systemic diseases, part 1. And with particular focus on neurological and musculoskeletal disorders. And very special thank you to every one of you here, because this is a beautiful Sunday afternoon and you're dedicating your time with us today. We know how valuable your time is. And we are so grateful to have such a dedicated community of professionals committing to improving children's pain. Well, pain in children with complex neurological and musculoskeletal disorders is often very challenging puzzle, and it can be very difficult to decode, very difficult to assess, and can profoundly impact a child's quality of life. So understanding the unique nature of this pain, from like how to assess a kid with severe neurological disorder to the complex regional pain syndrome, to the deep aching pain of various musculoskeletal disorder, is absolutely critical to provide a compassionate and effective care. So this is precisely what we will be exploring today. So today we are in excellent hands with our wonderful moderator team. I'd like to take a moment to introduce my fantastic co-moderators today. And firstly, it's me. Well, I'm a consultant working in the Department of Anesthesiology and Perioperative Medicine in Hong Kong Children's Hospital. And I'm currently leading a very small pain team in the hospital. And I'm also chairing the sedation committee. And my interest is obviously in pediatric pain and sedation, and also in pediatric peri-op anxiety management. And also we have our second moderator. This is Dr. Kim. Okay. Dr. Kim is an anesthesiologist and also an adult and pain physician. She currently leads the ASPA Pediatric Pain SIG. In Manila, she is the clinical associate professor and division chief of pain medicine at the Department of Anesthesiology at the Philippine General Hospital. She is also the session head of the pediatric pain at the Philippine Children's Medical Center. And one of her current quality improvement projects include improving pain in children with cancer in collaboration with the hospital's pediatric department and St. Jude Children's Research Hospital. Her other pain-related interests include pain education. Also, we have Dr. Farah. Okay, Dr. Farah is the consultant in the pediatric pain and palliative care unit in the University Malaya, and her interest is also on pediatric chronic pain and pediatric palliative care. So now I'm going to hand over to my colleague, Dr. Kim, who will go over, Dr. Farah, Dr. Kim, yes, who will go over the important details to ensure you all have a smooth viewing experience. Thank you once again for being here.
Thank you, Vanzi. I think, Kim, shall I do this?
Yes, I'll let you do this.
Okay, all right. So I'll just go through some housekeeping announcements. Good afternoon, everyone. Well, good afternoon from Malaysia. Just a quick housekeeping announcement. So there will be Q&A sessions, and how you can ask your questions or share your comments would be in the Q&A section. We have disabled the chat and raise hand functions. And our moderators, well, me including, will highlight your questions to the appropriate speaker during the panel discussions. Some of the questions will actually be answered by text by the appropriate speaker after their presentation, and we can go through them as well. There will be live polling. We'll be running live polls, so that's exciting. You'll be prompted to answer the polling questions when the poll is launched. Just keep in mind that you have about 30 seconds to respond and submit your answers. And we will share the results soon after we end the poll. And once the results are shared, you may close the poll so that you can see the slide shared by our speakers. And the close tab is just on the previous slide, top left-hand corner. Post-webinar, you'll be given a post-webinar survey that's automatically generated, and it will be forwarded to everybody who's attending today. Following filling up this survey and sending it back in, you will get a certificate of attendance. The webinar survey will be emailed to you tomorrow at 5 p.m. Singapore time, just to make sure that you've got your full name and email keyed in correctly, because that will appear on your certificate of attendance. There will be recorded sessions, and this will be in the Asian Society of Pediatric Anesthesiologists website. The the website address is as seen. It'll be on Facebook, ASPA 2000, and you can also catch us on ASPA Flex on YouTube. And when you go watch these sessions, also hit like and follow us. And I think I'll hand it now to Kim.
All right, thank you very much, Dr. Vancy and Dr. Farah. So I'll be starting off this webinar, and I'll be introducing our first speaker for this afternoon, at least in Manila, in Singapore. Dr. Avinder Kaur was here to talk about decoding pain in pediatric neurological disorders. So she is a pediatrician and a fellow of the Pediatric Palliative Medicine under the Ministry of Health Malaysia. She's also a trainer for the Malaysian National Training Program in Pediatric Palliative Care and a member of the National Pediatric Palliative Care Technical Committee, still in Malaysia. Her interests, of course, include palliative care, caregiver burden, which is I think very important as well, not just the looking after the patients, as well as research in pediatric practice. Good afternoon, Dr. Avinder. She has kindly prepared a poll question for us. I'm always very excited to watch the number of our participants increase as we go through the webinar, Dr. Vancy and Dr. Farah. So we're now up to 111 participants, so that's great. So I'll start off with Dr. Avinder's poll question. And we would appreciate if the participants would answer, which of the following is the most indicative of pain in a non-verbal child with severe neurological impairment? So there is only one choice. So letter A is increased spasticity, grimacing, and unexplained crying during repositioning. B is consistent smiling and stable vital signs during routine care. C is reduced muscle tone, relaxed facial expression, and normal sleep pattern. While D is lack of verbal communication and reliance on gastrostomy feeding. You have, I think, half a minute to answer this, then we'll have a little discussion with Dr. Avinder. Seems like a lot of the some of the answers. Okay, so our participants answered letter A the most, so that's increased spasticity, grimacing, and unexplained crying during repositioning. Can I invite Dr. Avinder to discuss a little bit which actually is the correct answer for your poll question?
Hello, everyone. Good evening from Malaysia as well. Thank you, Dr. Kim, for the introduction. So yes, I guess I don't need to give this talk. Majority of people have answered it very well. So the answer, which of the following is most indicative of pain in a non-verbal child with severe neurological impairment? Yes, so the correct answer would be A, increased spasticity, grimacing, unexplained crying during repositioning. All of these are signs that the child is uncomfortable and hence can be indicative of pain. The other answers are not very accurate. And so if you look at if you look at number 2, there is consistent smiling, which could also mean something. Stay tuned to my talk, but the rest of them are not really. So maybe we can listen to the to my sharing, and then we'll discuss more later.
Thank you, Dr. Ravinder. I give you the floor.
Thank you. Hello, everyone. My name is Avinder. I'm a pediatrician and a pediatric palliative medicine fellow from Malaysia. So today I'd like to share about decoding pain in pediatric neurological disorders. As pediatric neurological disorders is a very wide topic, I'd be focusing on children with severe neurological impairment. The objectives of my sharing today would be to convey the importance and complex nature of pain in children with severe neurological impairment, or SNI, highlighting definitions of SNI and the total pain concept. We'll also be looking into strategies for pain assessment and how to outline a holistic, individualized, multidisciplinary approach to pain management in these group of children. This is a picture of a child with severe neurological impairment, and here we can see that he's very happy, he's very much at ease, and if only all our patients with severe neurological impairment looked like this and were happy and at ease like this. So children with severe neurological impairment often have severe to profound intellectual disabilities with lifelong limitations in verbal communication, and often there is a coexisting motor impairment such as cerebral palsy. Causes include genetic, metabolic, neurodegenerative, sometimes CNS infections, traumatic brain injury, or it may be idiopathic. Pain is a frequent and significant problem in children with SNI, and the highest frequency and severity are in those with the greatest impairment. Studies have shown that daily pain is reported in nearly half of children with SNI, and this pain that they experience is often a moderate or severe pain. Children with SNI remain vulnerable to under-recognition and under-treatment of pain. Let's look at Leo's persistent discomfort. So Leo is a 7-year-old boy with spastic quadriplegic cerebral palsy. He had of GMFCS level 5, which basically means that he is totally ADL dependent. This was from an insult from birth, a hypoxic ischemic injury at birth. He also has epilepsy and he's on treatment. He also has gastroesophageal reflux disease and chronic constipation. So functionally, he is non-verbal, he is fully dependent on his parents and caregiver, and he is wheelchair bound. So his parents come in complaining of increasing irritability and crying over the past 2 weeks, especially during repositioning and bathing. They're not quite sure what the source might be, but they notice that Leo has been feeding less and sleeping poorly, leaving him and his parents exhausted. So what is actually happening here? And how can we help Leo and his family? So pain assessment in children with SNI can be very complex and challenging due to their inability to communicate verbally. So the goal is to identify this pain and then track response while intervening, keeping in mind the concept of total pain. Pain behaviors is an important part of assessing pain in children with SNI. We heavily rely on pain behaviors to give us a clue. Hence, it is very crucial for clinicians and caregivers to understand what a child's baseline pain behaviors might be and recognize changes from baseline when pain occurs. So some examples of pain behaviors could be, as described here, vocalization. That means they might be crying, moaning, gasping, or they may be grimacing, frowning, or they may be more difficult to console compared to before. There might be changes in their interaction, in their sleep, in their movement, or tone, and physiological features. So as you can see in the diagram here, this child has clenched teeth, a very serious face. The legs are tense. He's fisting, and if you could hear him, he'll be whimpering, moaning, and definitely not as consolable as before. So to assess these pain behaviors, we have many tools as listed here in table 4. My favorite is the revised flag, which looks at the face, legs, activity, cry, and consolability. I also like using the revised flag because they actually have a place here where the family members or the caregivers can write what this individualized behavior for that particular child is. This can be very helpful to recognize how severe the pain might be, or is the management helping as we reassess his pain behaviors later on. There's also the individualized numeric rating scale. So as you can see here, parents can document if the child is in no pain, what he does, if the child is in mild pain, what he or she does, and so forth. There's also the NCCPC post-operative version, and this is the revised non-communicating children pain checklist, and we can also use the pediatric pain profile. It is very important while assessing pain in children with SNI that we take a comprehensive history and do a thorough physical examination. So I love this diagram by Lisa Ann Rasmussen in her paper that was published in 2015. She gives us a diagram that looks at the child from head to toe, identifying different possible sources of pain that the child may be experiencing. So it's very important to identify and treat these hidden sources, look for other underlying causes. And of course, we know that these children will be on multiple medications. So it's important to review this medication to see if there was a recent change in the medication that may be causing new symptoms or new pain. Pain sources can sometimes be complex and multifactorial, such as central neuropathic pain. So this might be due to damage and dysfunction within the CNS, which can amplify the child's pain experience and cause symptoms like visceral pain. Another component is autonomic dysfunction. This is also quite common and may present as abdominal pain, retching, constipation. There might be change in the vital signs, and the child may also be sweating profusely. Children with SNI can also have a varied or different sensitization to pain. They might have wind-up phenomena where even a mild stimuli can cause severe pain, or they might have visceral hyperalgesia. Hence, it is common for children with SNI to experience more than one cause of pain, and often there's a mixture of nociceptive and neuropathic elements to that pain. We should also consider the total pain concept, which means that we should also always look into the psychosocial and spiritual aspects of that pain experience. We should look to see how the pain that the child is experiencing impacts his or her sleep, impacts his or her family interactions. And we should also understand caregiver responses to pain, as this is very important to understand if the child is withdrawn, to understand if the caregivers are emotionally available for that child. And when we assess these things, it's also important to keep in mind what is this particular child's cognitive and emotional development, as they may respond, they may behave to pain differently. We should also use a multidisciplinary approach when assessing pain. So it is useful to look at what the hospice or home setting experience might be, as it may give us a clue to what the psychosocial context is. And don't forget the parents, as they spend most time with their children and often are very accurate in identifying the child's pain and can provide specific pain behaviors which will be useful to us. This is a flow chart from one of my go-to papers by Julia Howard on pain assessment and treatment in children with significant impairment of the CNS. So I've covered most of this in my previous slides, but what I'd like to highlight here is that if we notice that the pain behaviors may be recurrent, there's recurrent irritability, it may be worthwhile to initiate empirical medication trial, such as with gabapentin, while considering further studies. So now we move on to management. It should always be multimodal strategies, always be using multimodal strategies such as pharmacological, non-pharmacological, interventional or regional techniques, and family education and involvement. So for non-pharmacological strategies, comfort measures can be very useful, like swaddling, repositioning, massage. Besides that, supportive equipment, such as in this picture, you can see like the supportive pillow can help to minimize positional pain. Sensory techniques such as the vibratory mat can also be very useful, as warm baths and music therapy may be as well. Environmental control helps to keep the environment calm, helps to relax the child. And as I shared earlier, a lot of children with SNI have GI, gastrointestinal manifestation of the pain, such as visceral hyperalgesia. And so GIT management strategies may be very helpful as well. These strategies are mainly to reduce GIT distension, and some of the things that can help is gastrostomy tube venting, reducing feeding volumes, and of course managing constipation. Some of the things that we do at our center here would be to transition the child to perfuser feeding or infusion feeding while the child is experiencing pain, as this will help with feeding volumes and gastric distension per hour. So we look into pharmacological management as well. Some of the general considerations include the WHO pain ladder, of course, two-step for pain. And sometimes we may need to combine medications for improved efficacy, and definitely management of the coexisting problems as well, such as constipation and GERD. So this slide is a bit busy, but I'd like to highlight some of the medications that we use. Gabapentin can be very useful in neuropathic pain and visceral hyperalgesia, as well as dysautonomia and spasticity. TCAs, if available at your center, such as nortriptyline, can be useful as well. Sometimes it's used together with gabapentin for neuropathic pain and visceral hyperalgesia. Opioids is very useful. We use morphine for moderate to severe pain, and methadone. So in my center, my consultant uses methadone, a trial of methadone for some children with SNI with very bad visceral hyperalgesia, and it has shown to help. And if these group of children have autonomic dysfunction, clonidine might be beneficial as well. So some specific considerations would be to check and see what the assumptions or beliefs of the caregiver or family are, because if they don't believe that this is pain or they don't believe in the treatment, then this will affect the management that they provide for the child at home. It's also important to take into account the neurodevelopmental differences. Some children with SNI may have atypical pain behaviors, such as the freezing phenomenon, smiling, or self-harming. And children with autistic spectrum disorders may experience, may have different pain behaviors and may behave differently. It's also important to look into the role of caregivers, to look into their caregiver burden, to see what their anxiety levels are. Are they emotionally available for their child? As all of this can worsen the child's pain experience. And sometimes we know that some symptoms may be intractable, and so we may not be able to fully resolve the pain behaviors or the pain. And so it might be worthwhile to discuss parental expectations and tailor care accordingly. So let's look at Leo's persistent discomfort. So to recapitulate, Leo is a 7-year-old boy with SNI who has presented with increasing irritability and crying for 2 weeks. So doing a thorough history and physical examination, we noticed that he has pain behaviors such as grimacing, arching, increased muscle tone. His revised flex score is 6/10. There's associated symptoms of constipation, and he also has occasional coughing after feeds, which could be suggestive of reflux. And on examination, we noticed that there's an increased tone in his lower limbs. There's mild hip subluxation with tenderness, and there's also abdominal distension, but there's no signs of infection. Pelvic X-ray shows left hip subluxation, and the abdominal X-ray shows moderate fecal loading. So looking into the psychosocial and spiritual parts as well, we noticed that his discomfort has led to irritability and withdrawal, and these parents are also deeply distressed and helpless, which can impact their emotional availability and the child's overall coping mechanism. So I'd like to highlight here, we looked at pain behaviors. Always look for hidden sources, such as here the hip subluxation, and take into consideration the total pain experience. So this is a very realistic situation. So often in our clinic, we can't sort of pinpoint the one thing that is causing the pain behavior, and often have to come up with differential diagnosis. So here in Leo's case, there's musculoskeletal pain from hip subluxation or spasticity. There's abdominal discomfort from constipation. There's gastroesophageal reflux as evident by his coughing during feeds. And there may be a component of neuropathic pain. So for his management, we of course want to provide immediate pain relief through using oral morphine and paracetamol. And we definitely want to look at the underlying causes. So head to toe, look for hidden sources, and so treat the underlying causes. So here we definitely want to treat the constipation and also the GERD using, we use omeprazole and domperidone, but depending on what's available at your center. We also want to engage the physiotherapist and orthopedic to have a look, multidisciplinary, to have a look at the hip subluxation and how we can help reduce that pain experience. Using non-pharmacological measures as providing comfort, using warm compress, a massage, this can all help with the child's pain experience. And most importantly, we need to have ongoing assessment, ongoing reassessment of this pain, review feeding intolerance, review the impact of this pain on the sleep and family interactions. And if we're seeing this patient in clinic, it might be worthwhile to review the child in 2 weeks to titrate medications to see if our intervention is working. So at this point, if the child comes back, if the pain is recurrent, chronic, we may want to consider adding gabapentin straight away and treating for neuropathic pain while further working out for other causes. So if I look at the diagram that I've put here, the assessment and management of pain in children with SNI really looks like this. There's so many things involved, so many investigations, so many symptoms, so many management. And so my take-home message is really pain in children with neurological disorders is multifactorial, and often there are a lot of hidden sources. Hence, we should have a robust assessment, taking into account the behavioral aspects, caregiver input, and providing a multimodal, individualized management strategy to reduce pain and suffering. These are my references. Thank you.
Thank you very much, Dr. Avinder, for that very wonderful, comprehensive, and really informative talk. We will have a Q&A after all speakers have completed their talks. So now hand over to Dr. Vancy to introduce our next speaker. Thanks
Okay,
again, Dr.
thank you.
Avinder.
Thank you, Dr. Kim. Okay, our next presentation is highly anticipated, and we will turn our focus to a very complex and challenging pain condition, that's the complex regional pain syndrome. It is my great privilege to introduce our next speaker, Dr. Alan Rao. Dr. Rao is an accomplished pediatric rheumatologist based in Bangalore, where he practices at both the Manipal Hospital and also Indira Gandhi Institute of Child Health. His professional interests are a testament to his expertise with a focus on conditions like systemic onset of juvenile idiopathic arthritis and systemic lupus erythematosus. Furthermore, his work in the realm of novel autoinflammatory diseases is truly groundbreaking, as his team discovered the leishmania, which is a new autoinflammatory disease. So without further ado, may I introduce Dr. Anand and his opinions on the complex regional pain syndrome. And before we move on, we have a poll question. So be ready. So which is the gold standard test to diagnose a CRPS? Is it A, MRI of the affected limb, B, nerve conduction velocity of the nerves of the affected limb, blood tests, including CBC and acute phase reactants, or none of the above? So we have 30 seconds for each of us to cast our poll before we end it and share the results. So I can see that a lot of us are casting their votes already. It is a very challenging topic for sure. Okay, so I'm going to stop the poll now. Okay, maybe Dr. Anand, can you comment on the poll results and also give us?
You have a very smart audience, that's what I can say, because 44% of them have answered it right, that it is a clinical diagnosis, and you none of these tests are going to be very useful in diagnosis. You just need to clinically diagnose it. I think my talk will cover on how to achieve a diagnosis of a CRPS, and I think it will beautifully answer the question which has been posted as a poll question.
Okay, excellent. So we can't wait right now. So let's start the next presentation on the complex regional pain syndrome. Thank you.
My name is Dr. Anand P. Rao. I'm a pediatric rheumatologist at Manipal Hospitals and Indira Gandhi Institute of Child Health. I'll be speaking today about complex regional pain syndrome. So let us start with a case, because that's the best way to have a learning when it comes to clinical scenarios. This is a story which happened very recently, about a week ago. A 13-year-old adolescent female was brought with complaints of swelling of the right forearm along with the right hand for the past 9 days. She had skin rashes which were noted over the affected limb for the last couple of days. There is history of viral upper respiratory tract infection a couple of weeks earlier. There is history of drug practice for the past month daily, which she, being right-handed, used to use the right hand to beat the drums. And other relevant history is that the patient is an introvert with a very sensitive nature, according to the parents. This came out on direct lead question. Physical examination revealed that she had, as you can see with the pictures, dorsal fullness with fullness of the digits also to some extent, as you can see, as compared to the contralateral limb, which is the left limb. And there are some erythematous rashes which were noted over the right forearm. The edema extended from the hands to the forearm up till the lower arm. She was a comfortable adolescent. Vitals were stable. The systemic examination was normal. The right upper limb revealed erythematous patches, which I showed earlier in the images. Inability to make a fist because of the edema. There is allodynia, wherein even a mild feather-like touch used to induce pain. Hyperesthesia, a mild painful stimulus used to create symptoms which are totally out of proportion. And it was remarkably cool to touch as compared to the opposite limb. The investigations, as you can see, was pretty much unremarkable, with no evidence of anemia, normal counts, normal platelet counts. ESR was bang normal, peripheral smear was not. So what is complex regional pain syndrome, or CRPS as it is known as? It's a type of amplified musculoskeletal pain syndrome. The other variant being fibromyalgia, juvenile fibromyalgia, or generalized pain amplification syndrome, which the speaker after me is going to speak about. It is a chronic intensified localized pain syndrome which is disproportionate to any inciting event. Like what happened with our child, just beating of drums elicited a pain which was out of proportion. The pathophysiology, there's usually central sensitization. So it's more a matter in the cortex. There's lower threshold for sensing pain. There is increased duration of pain. There's increased spatial distribution of pain, and there is increased amplitude of pain. I think more than me, the audience might be aware of it better because they deal with pain day in and day out. And there is a small fiber neuropathy, which has been described as the cause of the distribution of the pain. And there is an exaggerated local neurogenic inflammatory response. Substance P and calcitonin, like growth peptide, is elicited in the nerve terminals, which causes pain. So if you look at the busy figure from nature, you can see that trauma is the initiating feature. So you can see the trauma initiates an inflammatory response, which causes one inflammatory signs, which I just described in our patient, but it also causes peripheral sensitization. Now, peripheral sensitization causes central sensitization, which causes maladaptive neuroplasticity. So this causes disturbed body scheme, it causes severe dystonia, and it also causes hyperalgesia and allodynia. This is because of peripheral sensitization as well as central sensitization. And this is also associated, there's also a psychological component which causes increased catecholamine. And this catecholamine causes sympatho-afferent coupling. So wherein the sympathetic nervous system causes pain, increased pain. So it's sympathetically mediated pain. So what are the brain changes which have been noted in pediatric CRPS? There's functional MRI changes show abnormal brain activity in the brain children with CRPS. There can be changes which are seen in brain regions responsible for sensation, movement, and emotional processing. These neurological changes can persist long after the physical symptoms have resolved. So coming to the clinical features, it typically affects adolescent females, the mean age of whom is about 12 years. Emotional distress can be associated in many of these patients, and there is an abnormal perception of the affected limb. The clinical features of the affected limb, as I was describing, can be associated with allodynia and hyperalgesia, which is because of altered response and lower threshold in central and peripheral nervous system. There can be swelling and edema. There can be skin temperature changes, skin color changes, and hyper or hypohidrosis, which are predominantly the autonomic changes associated with this condition. There can be motor changes in the form of weakness or decreased range of movement and abnormal movements like dystonia, predominantly which have been described in adult patients. And there can be trophic nail and hair changes when the disease has been going on for weeks and months. So what are the types of CRPS? Type 1, also known as reflex sympathetic dystrophy, is usually not associated with any injury to the nerve, which can be documented. It's associated with trivial trauma or fracture like our patient. There is no evidence of nerve injury. Type 2, or also known as causalgia, is caused by partial injury to nerve or its branches. So how do we diagnose CRPS? Clinical diagnosis, it's a clinical diagnosis. There is no test which is gold standard. Labs usually are normal. MRI might reveal bone marrow edema. Diagnostic delay can lead to muscle wasting, joint contractures, and a significant psychological impact not only on the patient, but also on the family. So coming to the classification criteria, which have been validated in adults, but are being used in children for lack of any better criteria. The rule one is you need to have continuing pain. The patient should have pain which is out of proportion to the original injury, which I was mentioning earlier too. And rule two, you should have at least symptom in 3 categories, which are sensory, in the feeling of hyperalgesia or allodynia, vasomotor, wherein there are changes in skin color or temperature, pseudomotor or edema, when there is swelling or changes in the sweating like our patient had, and motor and trophic changes like difficulty in moving, weakness, or changes in hair or nail growth. Rule 3 is after you have one symptom in 3 categories, which I did mention, you should have the signs in at least 2 of the 4 categories, which I did just mention. So this is the medical documentation, what has been reported as symptoms. And 4, there should be no other plausible diagnosis, no other condition which can explain this condition better. So coming to treatment, it's an interdisciplinary treatment. We as rheumatologists tend to diagnose these conditions more often than the other specialists, but the treatment lies in the domain of a psychologist and a physiotherapist, along with an occupational therapist. It is basically involves mobilization and massage so that you can ignite confidence in the patient that the joint can be moved without much of pain. So gradually you go on mobilizing the joint and gradual massage. There are other techniques like towel rubbing, which decreases the peripheral sensitization of allodynia and hyperesthesia, graded motor exercise exposure. So gradually go on increasing the muscle, the physiotherapy exercises, which are going to gradually become more intensive. And what has been recommended is 5 to 6 hours of physiotherapy in the initial part, when the patient has been admitted as an inpatient. And subsequently, it can be taught to the parents so that they can continue to work on it as the child gets discharged from care if a trained physiotherapy help is not available. Contrast baths, which would include warm water baths with cold water baths over the affected area so that the sensitivity of the peripheral nerves in the affected limbs decrease. There's something called as mirror therapy, wherein you show the mirror to the normal limb and ask the patient to move. So you are trying to affect the brain, showing that with mirror therapy that your unaffected limb is also moving. So which gives confidence. It decreases the central pain threshold. It increases the central pain threshold and helps the patient to move her limb without much of pain as time goes along. Along with that, there is a component of cognitive behavioral therapy, which the psychologist carry out, wherein you find out what is the distressing signal which initiated the disease in the first instance. Then you look at the psychological impact of that triggering event and try to bring in positive reinforcement and positive thoughts which can decrease the pain which is happening with the patient. So pharmacotherapy, NSAIDs would have been used in many of these patients, but they're of no great help because this is not typically a pain which is associated with because of inflammation in the affected region. The inflammation is more in the nerves rather than in the tissues around the nerves. Neuropathic pain medications like amitriptyline and gabapentin have been found to be useful in those who are refractory CRPS patients. They relieve pain, improve sleep in refractory cases. Bisphosphonates, because they decrease the bone turnover, have also been found to be useful in anecdotal reports in pediatric CRPS. Investigational approaches for refractory CRPS include non-invasive therapies like TENS, which is transcutaneous electric nerve stimulation. And the second one, in this, you are going to use a handheld device which stimulates the skin of the affected limb, and this decreases the pain transmission from the periphery to the central nervous system to the cortex, which subserves the pain center. The other non-invasive therapy which has been found to be useful is repetitive transcranial magnetic stimulation, wherein you stimulate the brain, the part of the brain which perceives pain, so that you can increase the threshold of pain and make the peripheral pain decrease. So the other invasive therapies which have been used in adults more so for management of refractory CRPS is sympathetic blocks, wherein you block. This is predominantly used for lower limbs, spinal cord stimulation, and dorsal root ganglion stimulation. Now, dorsal root ganglion stimulation is a more newer version, wherein you stimulate the dorsal root ganglion, like how the pacemaker gives electrical impulses to the heart. You have a device which goes on stimulating the dorsal root ganglion, and this helps gate the pain perception. So the prognosis generally has been favorable. Most of them undergo spontaneous resolution in a few months. 92% of them show improvement in 6 to 8 months, especially those who have undergone intensive physio-occupational therapy and cognitive behavioral therapy. Recurrences are common though, with Shelley et al. Mentioning about 31% of patients having it over a 5-year period. Median recurrence time is 2 months. So it usually tends to recur. It tends to recur within the first 2-3 months. 80% of recurrences happen in the first 6 months of treatment completion. Pediatric patients tend to do better as compared to adults. I would like to thank the organizers of this wonderful the webinar for having me here, and would like to have some more interaction, and I would like to answer any questions if there are any. Thank you so much.
Thank you very much, Dr. Anand. And so audiences, you're welcome to cast all your questions in the Q&A box on the Zoom, and we will read it and then we will discuss it in the Q&A session after the coming presentation. So I'm going to hand over my time to Dr. Kim for introduction of Dr. Avinda.
Dr. Farah? Dr. Farah might just be having some connection issues.
No, that's because Dr. Farah
Okay.
got to turn on the mic.
No, that's all right. I'd like to invite Dr. Farah to introduce our...
Thank you, Kim. Thank you.
Thank
Right,
you.
as I was saying, so we'll go from CRPS to growing pains, a very common complaint among children. But Dr. Shahara Jentika today will take it further, growing pains and beyond, understanding non-inflammatory pain in children. Dr. Jentika is a pediatric palliative medicine specialist. Always nice to meet a colleague from abroad. She's from the Aborian Medicare Hospital in Palawan, and she's a lecturer with the Palawan State University School of Medicine. And her interests would be advocating pediatric palliative care in low and middle income countries, building compassionate communities in resource-limited settings, and medical education. And before the talk, we have, as always, a poll for you to look back at your practice in the last 1 month and see if you've seen at least 3 children with a complaint of low back pain. It's too bad I can't answer this as well. So 30 seconds. All right. So majority have not seen at least 3 children. Maybe they've seen fewer than that. But then all the more reason to listen to this talk. So Dr. Jentika, I'll let you continue with the talk then.
Good day. Today, we'll discuss common non-inflammatory musculoskeletal pain syndromes in children, conditions that are benign but often distressing to families. The learning objectives are the following. By the end of this talk, you should be able to recognize the major syndromes, identify red flags, and see how these conditions intersect with your anesthesiology practice. Just a disclaimer, this topic is very broad to discuss in 20 minutes, so we will only be focusing on a few commonly known musculoskeletal pain syndromes in children. Generally, many studies in children were not robust. There is a lack of validated diagnostic criteria, and existing studies are quite very few and outdated. When we say non-inflammatory, we mean that these children have pain but has no evidence of inflammation, like swelling, warmth, redness, or raised inflammatory markers. Remember these cardinal signs, as these will guide you in diagnosing musculoskeletal pain. Musculoskeletal pain is a common complaint in children, although I would say otherwise in my own medical practice. Despite being benign, the pain can significantly disrupt the child's life and worry families with negative impact on their school, daily activity, family function, and has high cost to healthcare system. Studies have reported the following generalities in chronic widespread MSK pain syndromes. Girls experience more musculoskeletal pain than boys. Psychosocial variables affecting pain prevalence include anxiety, depression, low self-esteem, other chronic health conditions, and low socioeconomic status. In fact, children living in low-educated, low-income families have a 1.4-fold increase in the odds of having back pain. The incidence of chronic widespread musculoskeletal pain peaks in older adolescents. Multiple common symptoms like joint pain, headaches, abdominal pain in childhood are associated with a moderately increased risk of chronic widespread pain in adulthood. In the background of developing musculoskeletal system in children with pain syndromes, this clinical process is happening. It starts with a localized pain that further intensify and radiates to other areas now associated with reluctance to mobilize and avoidance of movement, hence reducing fitness and further increase the pain. This immobility leads to muscle spasms, postural and gait abnormality. And with this gait alteration, it leads to compensation of other vulnerable sites like the lower lumbar, anterior knee, and lateral aspect of pelvis that further produces discomfort. Though this may not always be present, other associated signs and symptoms that you may observe with these syndromes are the following: hypervigilance and greater pain sensitivity. It is unclear whether this is caused by fear of pain or increased sensitivity of pain signaling. Clinically, this presents as young people describing unbearable pain on minimal skin contact and heightened fear of being touched, for example, on examination. Second is perceived thermodysregulation. It is commonly observed among adolescent girls where limbs are particularly cool and mottled. Third is autonomic dysfunction. Pain is a powerful stressor that activates the sympathetic system that leads to tachycardia, hyperventilation, cold sweats, blurred vision, abdominal pain, and extreme pallor. Children look unwell during these episodes of increased pain. And lastly, musculoskeletal disequilibrium. These young people are still growing, often in their peripubertal growth spurt, and musculoskeletal pain can have lasting effects on the final positioning. The adaptive positioning with leg or abdominal pain affects the gait and resting positions, and thus alters the load on the spine and pelvis. The four most common syndromes that we'll go through today are the following, each with distinct features and implications for anesthesiologists like you. The first one, let's start with the most benign or less serious among these. It is growing pains, where the classic scenario is a healthy child waking up at night crying from leg pains, but is perfectly fine by morning. This is common among 4 to 12 years old, and it is characterized by bilateral leg pain, intermittent, usually at night, where there is no limp, no systemic symptoms, and there's normal examination. It is easily relieved by simple massage or analgesics. The most important intervention for this is reassurance. In the pre-op clinic, we must reassure families and confirm that there are no red flags, and these children can safely proceed to anesthesia. Second is low back pain. Low back pain is more common among girls and increases with age. There's no clear etiology. However, there are risk factors to it, such as poor physical conditioning, reduced strength in muscles that support the back, intensive sports, and reduced hamstring length. A prospective study of adolescents showed a strong correlation between low back pain, emotional and behavioral problems, as well as other physical problems such as headaches, stomach aches, sore throat, and fatigue. It is generally benign and improves with physiotherapy. Next is benign hypermobility syndrome. There is undoubtedly an association between joint hypermobility in children and diffuse pain. However, the nature of this is poorly understood. Hypermobile individuals are often entirely asymptomatic and utilize their increased flexibility to advance in sports. However, around 50% of these individuals report hypermobility-related pain. It is more common in females, especially in Asian and African populations, with up to 40% of females in some races affected. Joint pain is the commonest symptom, frequently affecting the knee, foot, and ankle. And hypermobility is measured using the Baton scoring. However, this is not validated in children. In testing hypermobility, the Baton scoring asks the patient to do these maneuvers, and we score them as 1 point for each extremity if they are able to perform it. And another 1 point for that last maneuver, as you can see on your screen, where the child will try to reach the floor. On the other hand, hypermobility syndrome is hypermobility accompanied by other signs and symptoms, and it is scored using the Brighton criteria. Again, this is not a validated tool in children. However, it is useful in diagnosis of childhood joint hypermobility syndrome. There had been studies on these that had widely varied results in the use of this scoring criteria in children. But what seems to be clear is that majority of hypermobile individuals will not have significant pain or have any risk for specific musculoskeletal disorders, including osteoarthritis in later life. Joint pain is the most common symptom. However, cognitive, neurological, and visceral manifestations are frequent and may be more disabling than musculoskeletal symptoms. Autonomic dysfunctions may also be observed, like syncope, dizziness, and orthostatic hypotension. The management revolves around non-pharmacologic strategies. Like in pain management, they can use heat or ice packs and distraction techniques in order to help the child to keep their mind busy and not focus on the pain. Should you find it difficult to manage the pain, there must be other symptoms or factors that is influencing the pain. As we know, pain is a sensory and emotional experience, so there might be psychological factors affecting it. Then you can refer this child to a pediatrician or a child psychiatrist or psychologist. Next is strengthening exercise that are low impact that will help improve joint strength. Another is spacing, like planning activities to avoid getting tired or overwork, and spreading heavy and light tasks throughout the day. If there is joint pain with no associated congenital syndrome, it is more likely benign. And you can reassure the parents that there is no contraindication to anesthesia and there's no reason for delays. If you are highly suspecting other heritable disorders of connective tissue, like Marfan syndrome, that are usually associated with cardiac abnormalities, Ehlers-Danlos with propensity to arterial rupture, or osteogenesis imperfecta, like having fragile bones, you can refer to a primary care physician or pediatrician. If with disabling psychological manifestations or autonomic dysfunctions, you can refer to a child psychiatrist or a pediatrician. And if you find that the pain is very disabling, an early referral to pediatric pain clinics or pediatrician is important. The last syndrome is the diffuse idiopathic pain syndromes or juvenile fibromyalgia. Juvenile fibromyalgia is less common, but very challenging. These children have widespread pain and central sensitization. It is associated with fatigue, sleep disturbances, and headaches. The child's low mood is primarily associated with pain-associated disability rather than primary depression that is more common in adults. The diagnosis remains contested in both adults and children because diagnosis is purely symptom-based. And it is still debatable which classification criteria to use. There's also still no validated diagnostic criteria studied in children. Central sensitization that are usually characterized by allodynia and hyperalgesia are very common in patients with juvenile fibromyalgia. Therefore, you could expect that patients with JFM could have an exaggerated post-op pain. They often do poorly with opioids and would need multimodal pain strategies. Anesthesiologists play a key role in pain clinics as part of a multidisciplinary team. The lack of a single unifying pathophysiology is mirrored by a complex and non-specific approach to management of JFM. First, by reassuring the family that JFM is not known to be a progressive disease or associated with serious medical complications, families are much more willing to engage in pain management recommendations. There is no definitive treatment, but recent studies focus on non-pharmacological therapies such as cognitive behavioral therapy, exercise therapy, hydrotherapy, and acupuncture. Several guidelines by the European League Against Rheumatism, Canadian Pain Society, and the Association of the Scientific Medical Societies in Germany recommended amitriptyline, pregabalin, and duloxetine as useful adjunctive treatment to non-pharmaceutical measures. And here is a diagnostic approach that you can follow in diagnosing musculoskeletal pain in children. It is very important to take a complete history and physical exam. And we further look into presence of redness, swelling, or warmth. If there is, then we have to treat or you have to refer to a specialist or a pediatrician. If no, we further inquire whether there are systemic complaints or constitutional conditions like fever, weight loss, or rash. If there is none, you can go ahead in providing reassurance to parents and schedule a follow-up with the physician or if parental concerns exist. Usually, here you can diagnose the growing pains, low back pain, or juvenile fibromyalgia. As you probe further down the algorithm, you will inquire other features like change in activity, underlying illnesses or immunosuppression, or constitutional complaints, and abnormalities in physical examination. You would notice that most of these conditions are inflammatory, except for one that is benign under the abnormalities in physical examination showing hypermobility or laxity is the benign hypermobility syndrome. So here are the red flags that you have to take note. Unilateral nocturnal pain, which is not relieved by massage, nerve compression or damage, presentation in young children, because usually there are common malignancies in very young children, and constitutional symptoms like fever, malaise, weight loss. And always exclude malignancies, vertebral damage, infection and inflammation, and rare conditions like chronic recurrent osteomyelitis, longer hands, histiocytosis, or idiopathic osteoporosis. In summary, there is no clear etiology when it comes to the most common musculoskeletal pain conditions in children. And you always need to take note of the red flags, such as the swelling, warmth, redness, or systemic or constitutional symptoms. If you see these, refer to pediatricians or primary care physician. As cliche it may be, accurate history and PE is imperative in diagnosing benign musculoskeletal pain syndromes. Chronic pain management require multidisciplinary approach as it impacts physical and psychological well-being and their families. And lastly, effective treatments are greatly focused on rehabilitation and therapies. Thank you for listening.
Thank you very much, Cheryl. Thank you for your insights into musculoskeletal pain syndromes. Kim, I think I'll hand it over to you for the Q&A.
Yeah. So may I invite all our speakers to our virtual stage. And I'd also just like to invite as well Dr. Anu to join us. Dr. Anu is the head of our education subgroup in the SIG of pediatric pain. So great talks, and we really appreciate everyone's talk. It's Anu has given you so much challenge in giving you such broad topics, I believe, but you have found a really good way to summarize them and highlight the necessary information. I believe we have different our participants come from different backgrounds. We may have since this is an open webinar, we may have anesthesiologists as well as pediatricians and nurses in or allied health professionals in our amongst our participants as well. So, Anu, would you like to start off? I'm just really very interested. Dr. Anu organized the topics for today. And as an anesthetist, as an anesthesiologist, I'd like to find out from you the interest of combining or compiling this set of topics.
Yes. Thank you, Kim. So I know ASPA, as part of ASPA and as part of PPSIG, we've been doing some great work in bringing about awareness in pediatric pain. Um, so I think over the last 2 years, we have, and as anesthesiologists, most of us are extremely comfortable with acute pain, be it procedural pain, trauma, ICUs. We are there and we know how to do. And I think, I just say good luck. I've had the privilege of being trained both in pediatric pain and pediatric palliative care at SickKids and with the Two Worlds Cancer Collaboration. So that has been a very, wonderful learning experience for me. And I think over the last year, especially, I felt that I have met amazing people who are doing, wonderful, incredible work in pediatric pain. So for me, it was easy. I just needed to bring these two cohorts of people together. I just did the Venn diagram. That's it. So we have our amazing people from, I know Avinder and Shohara from the pediatric palliative care team, and Dr. Anand, who is doing amazing work at our hospital as a rheumatologist. Farah, I know I heard from again, so small society. So I know she's doing great work in Malaysia in pediatric pain. So is Mansi, who's just started her pediatric pain clinic in Hong Kong. So I think it was, we are doing amazing work, but this we need to just get in the right people who are passionate about pediatric pain and get this ball rolling, higher of farther.
Yeah, I think
Thank
that's
you.
really great. Thanks, Anu. Um, Dr. Mansi, how do you think this set of talks will help us anesthesiologists when we look after, children who have these conditions who are referred to us for anesthesia?
I think the talks are very enlightening, and
Mm,
it greatly summarizes the very key features of a neurological problem. Because with neurological problem, rheumatological problem, and musculoskeletal diseases, in fact, I have a lot of recalls when I was when I was listening, that I think of a lot of patients of mine. So as we are waiting for more questions, perhaps I can ask a question first. I'd like to ask about Dr. Anand about the CRPS. As you have mentioned, you have talked about there are a lot of different approaches of management, and that includes interventional pain as one of the results. So I'd like to, and you also said that is actually the outcome is actually rather favorable in the pediatric community, with a lot of them have spontaneous resolve within a few months. So what is your experience or of referring kids to for interventional pain strategies for CRPS?
Um, the CRPS, somebody asked me the question, how frequently do we see it? Out of about 3,000 rheumatology patients which we have in our cohort built up over the last 15 years, we've had about 10 to 15 patients of CRPS so far. It's much lesser than juvenile fibromyalgia, which runs in hundreds. We only have had about 15 patients, so roughly about one patient per year. So most of the times you should realize that CRPS, usually there is both in fibromyalgia and CRPS, there is usually a stressor.
mm,
This stress can be physical, but most of the times I think there is a mental stressor. So a couple of months back, I had a patient with systemic lupus who refused to go to the school because he had intense pain. But this boy has been having repeated such episodes of CRPS because he didn't like going to the school. So you will have bullying, or lack of a empathetic teacher in the school who is very strict, or marital discord at home, divorce. So these are the things which precipitate, which act as a trigger for the onset of these pain amplification syndromes. So it's always very important to talk to the child separately, talk to the parent separately, figure out what's happening in the family, which could have brought about this pain amplification, because there is always a central nervous system sensitization along with a peripheral sensitization which drives the disease or disorder. So it's always important to pick that up. Most of the times I try to do without drugs. It's important to involve the physiotherapist and the psychologist both, because they both have very integral role to play, because they'll have to the physiotherapist will have to look at how to alleviate pain, how to give confidence to the patient that he or she can move the limb um, without much of pain. So behavioral therapy, cognitive behavioral therapy, as well as physiotherapy techniques, which I did talk in my talk, which I did list out in my talk, are very important. Only those who don't respond, we tend to use medications like amitriptyline or pregabalin. I have more experience with using pregabalin as compared to gabapentin, but it is just a personal um, interest in that drug. It might not be greatly superior to gabapentin, because somebody had that question with regards to pregabalin versus gabapentin. So that's how I would do.
Okay, thank you very much, Anand. I believe we have more questions in the Q&A boxes now. So shall we answer them? Oh yes, Dr. Anu.
Yeah. So I just wanted to tell, like, Anand sir and I work in the same institute. So I have got references from the pediatric ortho department for pediatric CRPS. So I would say over the last 4 years, similarly, the incidence has been low. I've seen around 5 patients. And what I have noted is they present initially with intense pain. So when you ask them the pain scores NRS, it's usually more than 8 or 9 or 10. So that is where I found that as an anesthesiologist, we have this role of intervention pain blocks. So far I've had, I think at least out of 5 of them, I've used epidurals or peripheral nerve blocks in at least 4 of them. And once the pain comes down, or at least it's the cycle is kind of cut off, it's much more easier to get in the PT and the psychology team to help, to help the child with recovering from this pain cycle. So I would say initially acute phase interventional pain blocks are very useful.
Okay.
Yeah, thank you.
I think that's a very useful tip. So we need to arrive to help the patient about psychosocial model as well in the pediatrics.
Yeah, Dr. Farah, did you want to say something in your experience or in your practice? Have you encountered some of these patients who our speakers have given wonderful talks on?
Yeah, I think certainly the musculoskeletal pain syndromes, I think we see that quite commonly. And I think there's more of them out there that that don't come to us at all. I perhaps have a question for Sho. Investigation is a double-edged sword. And often you find that there is always either it comes from the patient parents or the patient themselves, or even their primary teams, because we're never the primary teams. They've always come from another doctor, another specialty, who would drive these investigations. And I think if you investigate really hard, you will find something. But that might not be what's causing this pain and this impairment in function. So, Sho, what do you think? How do you manage, or what's your approach to parents, families, or primary teams wanting to continue investigation and find something like a cyst in the bone and blaming that solitary cyst on the musculoskeletal pain?
I think this is where the accurate and really skillful investigation of the clinician is where it comes to play. Because if we think there are investigations that are not really necessary, that would only, cause confusion, then why should we do it, right? So if we think we're doing the right diagnostic approach, and I personally am very conservative with my management because of the way I was trained, and so I do really bunk on and really invest in more clinical diagnosis or clinical investigations first before I go further into like doing a lot of imaging and all that. But of course, if I find right in front of my eyes that this patient needs imaging or would benefit more in the imaging to get a clear diagnosis, then I would really explain a lot to the parents how important it is and how it would affect the management so that they can, be more involved, empowered in joining in the management of their child. Yeah.
Yeah, I think it's finding the right balance, hey, between investigating to rule out sinister pathologies versus initially relying on the clinical evaluation and examination. So I guess that leads me to the question in my mind as well. How do you explain that to parents that, look, right now, I don't know, we do not need any further investigation, or that we will initiate non-pharmacologic approaches rather than pharmacologic approaches initially? I guess that's a question for all the speakers.
So the thing is, it's um, the history and the clinical examination most of the time will lead you to the diagnosis. That's what I strongly feel, because we come from a resource constrained area wherein investigations don't come in handy, and it's been a blessing for us actually. The reason being, you rely on a history, you take a very detailed history, and you, with experience, you learn when there is a mismatch of effect and affect. Patients who's smiling in spite of having a lot of pain, whose effect and affect don't go hand in hand. When distracted, sometimes it might be useful looking at the patient in a CCTV while she's waiting, he or she is waiting in the waiting room, and looking whether what they're complaining, because many times we keep speaking to the parents of the child. The child is waiting outside. We send the child out while we speak to the parent, and I keep a by the corner of the eye, I keep watching what the child is doing. Many times, when they are not being observed, they are totally different children. So sometimes it's attention seeking, sometimes there is a um, problem in the family, sometimes there is a problem at school. So all these can contribute to a lot of these pain syndromes, especially the generalized pain amplification syndrome, as Giara has mentioned, which is juvenile fibromyalgia or CRPS. So we'll always need to weigh the pros and cons of doing more than what is necessary. What we normally do for these pain amplification syndromes is just as CBC and ESR, making sure that we are not missing out to see anything sinister, like an inflammatory disease or a malignancy. If your ESRs are high, then you're not looking at this. If your counts are a little bit skewed, are you looking at something else, which can come with similar manifestations? But if they are bang normal, if like our patient had, like CRP is normal, ESRs are normal, counts are normal, and the child has significant pain which is not being explained by anything else, I think we should wait, pause, talk to the patient's family, saying that, see, the thing is, there's no point in evaluating any further, because the more investigations we are going to do, the more anxious you're going to become. Because you will find, like Dr. Farah did mention, that you will find something on one of the investigations which will once again lead us on the wrong track. There will always be a red herring in any of the investigations which we do. So you need to be very careful when you order an investigation in a scenario like this. It's a clinical diagnosis, and it should be a clinical diagnosis until we come out with more sensitive biomarkers to predict, to diagnose and predict the outcomes of these patients.
If I may add, Kim, just to answer your question, I think building rapport with the family members and with the child is very important as well. And I think that is one of the ways that we can sort of start off, initiate, and then further convince the parents that, hey, we're here and we genuinely care about your child and we want the best for your child, just like you as parents want for the child. And so once they see that, I think then they would trust that, okay, this doctor wants the same thing as I want. And so maybe doing so many investigations or doing so many invasive management may not be the right thing to do at this point of time. And so I think that could be really helpful as well, to build rapport, to get them to see that, we're on the same page as you. Yeah, we're here to help.
And if I may, I also add to that. I totally agree with Dr. Anand and Dr. Avinder. What I also do or add to my approach in my personal and medical practice is that I ask a lot of questions to the parents because that's also how I gauge how much they know their child and how observant they are with the pain of their child. And I use that to gauge also how reliable they are in giving information to get me to where I want to go, no? And so it's also a way of like empowering the family and saying or telling to them that you have a responsibility to take care of your child and your voice is very important because the care of the child or the management is not just pharmacological, it's holistic when it comes to pain. So I totally agree with all the comments of the our speakers and everyone. Thank you.
Aren't those really helpful?
Mm.
Yeah, really helpful and very beneficial discussion and answers from our speakers. I think Dr. Vancy, there's a question in the Q&A that might be relevant from an anonymous attendee. I think it's quite relevant to the recent discussion.
Okay, that is how can I make the child cooperate or agree with the physiotherapy if they are already in severe pain? So, what are your inputs, like Dr. Anand? How do you convince the child to go undergo exercises when they are in pain?
Very true. It's a difficult area when they are in severe pain. I think it's the bonding which first you as a clinician have, and the second thing is the physiotherapist also should be very sensitive to the needs of the child, and he should once again, like Zia Hara did mention, that you need to build up that rapport. Dr. Avinder did mention that building up the rapport, gaining confidence, starting off slowly, taking baby steps initially, and building up as time progresses on. I did mention it in the talk too, that it is a gradual phased increase of the physiotherapy. You can't go on doing um, uh, significant exercises on day one. So show the patient that if you start with your joint mobilization, if you start with your physiotherapy, your pain is going to reduce. And positive reinforcement. You should say, I prefer to say that it's about fighting the pain. The pain is coming from within. You need to fight the pain within. Let's see how strong you are. So all these things being put out to the patient helps them fight that pain and come start off with the physiotherapy. But also in the same time, start with cognitive behavioral therapy with a psychologist too.
May I add to
Yes,
the
please,
question?
Yes,
Thanks, Dr. Tanan. Yeah, thanks, Dr. Tanan. I think another way to approach this situation would be actually to treat the pain, especially if the child is in severe pain. I think what may be beneficial would be to treat the pain and then get the physiotherapy to come in and manage. So I've actually had an experience with an adolescent child who had come in with severe pain. And although this child is known to me and I'm known to the family, and we actually do have a good rapport, but when the child came in, the child was just very irritable, just did not want to make eye contact with me, just really doesn't want to talk to me. And I can see where she's coming from because she is in severe pain. And so before I initiate other aspects of the treatment, I just gave her a bit of morphine, and then within 45 minutes, she's a lot calmer. Of course, in the meantime, try to make the room a bit comfortable, less noise, initiate the non-pharmaco as well, get the parents or familiar faces nearby, and then use distraction therapy. But I also gave morphine, and then after half an hour, 45 minutes, we could get the multidisciplinary team in, and then people could start doing different things and try to help this child. So sometimes I think like an acute dose of treating that pain in that scenario might be helpful as well.
Definitely. Yeah. And I think that's where Dr. Anu's earlier experience on using epidurals and peripheral nerve blocks may come in. Okay, it's very interesting discussion that we're having here. We,
Yeah,
however, oh, sorry, go ahead, Dr. Anu.
just to add, I mean, it doesn't always have to be like epidurals. So even if they're on simple analgesics like, paracetamol or ibuprofen, just optimizing the doses so that they take it, or the peak effect of these medications is during the physiotherapy time itself. That itself could be beneficial for them. And like Anand sir mentioned, so it has to be paced physiotherapy activity. So they can't just go, at a stretch go to 10 kilometers or 5 kilometers. It needs to be paced. That has to be emphasized. Otherwise, it will be very difficult to break that vicious pain cycle.
Yes, timing and pacing. So rhyming words. Both very important in these chronic pain conditions. Dr. Vancy, I think we have a few questions to address in our Q&A box.
Let's see. So there's a question about the COVID infection and vaccination. So, do you all have a experience on handling some pain syndrome post-COVID or related to the COVID vaccination? Personally, I do have a patient who has done a lot. I have two patients actually. One having some widespread pain, like juvenile fibromyalgia after recovery from COVID. And then the other one is having terrible headaches after the COVID vaccination. So I wonder if this happens to your locality as well.
Thankfully, in pediatric population, we haven't seen many. So there was one patient who came in from New Zealand. The mom was a doctor. The child had COVID and subsequently a lot of pains. But I think it was a dysfunctional family too. The long COVID syndrome has been described in adults. But thankfully for us, we haven't had to deal, at least in our center, too many patients with this long COVID syndrome. The one whom I saw, I think there was a component of a dysfunctional family, but per se, not much of experience with the COVID vaccine associated pain or COVID associated pain from my end.
How about Dr. Silhara? Do you have any experience with post-COVID problem?
I would say the same, probably same picture as Dr. Anand's experience. Not so much in pediatrics, and I think what I would like the participants to really, especially anesthesiologists, to get from this session is there's a lot of need to do more research in the aspect of pain, especially in children. Like until now, like I'm seeing the references, they're still saying that there's a lot of variables and there's a lot of non-validated criteria for children. So I am more interested and more encouraged to to see further improvements or developments in the research in the in the aspect of pain in children. So I think that's something that I would like to encourage everyone.
Yes, and Dr. Avinda, do you have anything to add to? How about in Malaysia?
So we haven't really seen any long pain from long COVID as well. I don't really have much experience with that. So similar to what Dr. Anand said. Yep. Thanks.
Thank you.
Doctor, I know that Dr. Show is answering the last question, but would you like to answer it live instead?
Pregabalin, as I said, both complex regional pain syndrome and juvenile fibromyalgia tend to be seen in patients, children who are pre-adolescent, adolescent, or post-adolescence. So most of the times, our usage of pregabalin has been in that age group, usually in the second decade of life, not usually in the first decade of life, because these conditions we don't see in the first decade. Most of the times it's 10 plus. So that's when we have used it. The earliest patient must be around 9 or 10 years of age, not more than that. Not less than that, rather.
I think as well it's to depending on the country. I think it depends on the approval. Each country I think has its own approval age for these medications. Some country would approve its use in adolescents. And it's also just one of those medications that at times can be associated with suicidal ideations in the adolescent age group. So maybe that's just the caveat or the caution in using these medications as well. And I haven't looked at the most recent literature on the cause of that, but I believe that there isn't anything identified as yet as to why it causes suicidal ideations in some in the younger age group. Yeah. I have a question for Dr. Avinder. I remember when I was a trainee, a pain fellow, it's quite daunting, when you're called to see a patient who has neurological conditions and you're being called urgently because the patient is crying. And it's very difficult to console, and that patient is causing so much distress amongst the staff looking after that patient as well. What do you have any suggestions as to one, how to approach these patients initially, and as well as what initial management or which management would you prioritize?
Thank you for the question. I think that's a very realistic question. As you speak the question, I can imagine the scenarios that I've been through before. Yeah, so it is very daunting, I think, because in children with neurological disorders, they're non-verbal, and so it's quite tricky. And also, you don't know what their pain behavior, especially if the child is not known to you, then you don't know what their baseline behaviors were. Is this a pain behavior? Is this acceptable? Is this not? And so, even in my poll question earlier, like if you look at answer B, it says smiling. Smiling can actually be an atypical pain behavior, but then you wouldn't expect the vital signs to be normal. Right? They might be a bit elevated. So I think it's a very difficult scenario. I think there's no right answer, and everybody might approach this differently. But some of the things that I would do to sort of maybe ease the situation. Number one is I try my best to come into the situation in a calm demeanor. I try to come in calm. I try to come in with a smile on my face. I try to come in not panicky and not anxious. Although in my mind, I might be a bit anxious. Okay, how am I going to treat this patient? What will be best for this patient? So that the parents, when they see me, are hopefully a bit more calm. And then they may transfer that calmness to the child, right? Because they're the familiar person. I wouldn't be able to transfer that directly to the child, because especially if SNI. That's number one. Number two would be, I would address what is most time critical or what is the most acute thing at the moment. But before I do this, I would also do a quick head to toe. I think that that diagram is always at the back of my mind, like a quick head to toe, like what is actually happening with this child, quick head to toe. What can I see? Is the child breathless? Is that abdominal distension, vomiting? And often the common things in children with SNI are the reflux, constipation. These are all very hidden sources. If there's a catheter there, I would like to see if the bladder is draining actually, or is it blocked? Is the line tissued? Is there thrombophlebitis? Is there a pressure sore? Common things first, and then try to treat them. So in a lot of my children with SNI, a lot of their pain actually comes from the gut. And studies have shown this as well, like a lot of the pain comes from the gut. And so simple things like treating the constipation, quickly giving a Revin enema, and then of course following up with, lactulose or Forlex, can actually be very helpful. Yeah, helpful here. So I would treat the acute conditions and then plan for something greater. And then I think the other thing that often helps is to let the family and the child know that, hey, I'm coming back. Like I've done all these things, but I'm going to come back in 10 minutes. So we see how this works, maybe in 10 minutes, half an hour, and then I'm going to come back. And I think that sometimes can reassure that the family as well, and hopefully, provide more benefits to the child. I hope that answers your question.
Yes, thank you very much. Calm demeanor. All right, thank you for that. maybe someone would just like to type up an answer for our last question in our Q&A box. I think Teddy is already telling us that we've asked enough questions from our speakers. All right. In the interest of time, our speakers will answer any remaining questions in the Q&A box, or you can also get in touch with us if you have further questions. So just a reminder, those are very very it was a great discussion. How do you other panelists feel about that? I thought that was really helpful off the bat. After this webinar, I feel like our participants will be armed or have a lot of takeaways already that they could apply. What do you think, Dr. Farah and Dr. Bensi?
I think it is very enlightening and very stimulating. In fact, I learned much more, much more after these presentations. Thank
Yeah,
you.
I can see you taking down notes.
And yes, I did, and I love the Q&A sessions as well. Actually, I have a lot of questions still in my head, so probably I need to ask later.
Dr. Farah?
Yeah, I echo Vancy. I'm glad I'm not the only one taking notes. Happy to hear that she was doing the same. I think there's a lot to learn here. I think when we talked about earlier to my question about investigating and the primary team investigating more, I think these webinars need to go out there to other practitioners. I think people don't know that, chronic pain can happen in children, and often, you need to stop investigating. And I think it's about getting the message to our other healthcare colleagues out there as well.
Very good. Well said.
And
Well said.
Shaw also made a good point about research. I think we don't even have prevalence data, I think, this side of the world. So maybe we can work together, Shaw. I've already marked, I'll email her after this.
Yeah, hint to our SIG research subgroup.
Yeah.
Some topics that can be used there.
Absolutely. I think we need numbers out there.
Yeah.
Yes, I believe we have some announcements to make as well. Shall we announce them now?
Yes.
Can we have the next slide, please? Okay. So yes, so the recorded session of this session will be available in the website and Facebook and also YouTube later. And also September is the Pain Awareness Month. So so you're welcome to share what is your pain activities in your localities with us by joining us in the Pediatric Pain SIG in ASPA. And upcoming, we have a exciting workshop on the pediatric perioperative pain workshop. This is our first workshop to be held on October 11th, that's next month. But unfortunately, it's already fully booked. So we are looking forward to the next one, hopefully very soon. And this workshop is aimed to provide some very essential pain knowledge. It's a full-day workshop, a target for senior anesthetists who occasionally treat children, some new anesthetists, surgeons, pediatricians, nurses, allied health professionals. So if you're interested, you can reach out to our SIG with this email at the box below, and so that you can now stay tuned.
All right. Just this announcement. So this is a webinar that's open to anyone, for anyone to attend, even if they are not members of ASPA in the pediatric pain SIG. But we do want to let everyone know that anyone can be a member of the pediatric pain SIG. You don't have to be an anesthesiologist. You do have to be a member of ASPA though. And for now, membership to the SIG is still free. And we have started providing like boutique interactions, panel discussions with our members. So if that's your thing, just send us an email and we can send you a link on how to become a member and be a member of the different subgroups as well. So for our members, save the date. We do have an annual general meeting and election on the 16th of November in 2025. I am smiling because I am handing over the lead position to someone else now. And so the different leads or the different heads of the subgroups will be nominated or will be coming from the subgroup members. And the next lead will be chosen or will be coming from the present or current subgroup heads. So kindly check your email for your official invites in the coming weeks. Any more announcements? Anu or Dr. Vancy, would you like to just talk about ASPA a little bit more?
Yes, so yeah, actually, a lot of this is already covered by you, Dr. Kim, but we are a nonprofit organization, so we need support more than just a membership. We also need some financial support. So if you're interested and if you're generous, please do scan the QR code and donate, and so that we can sustain our collaborations and we hope that we can provide a better standard of care of pediatric anesthesia care in Asia. And speaking about researchers, just now we mentioned about we need a lot more researchers, and we are going to have a webinar also on the 16th of November. That's the same day as our AGM, is to enhance the collaboration in pediatric anesthesia research on a Zoom webinar. So we are going to see what we can do to do more together, joint efforts in the Asia community to help more of our patients. And also, most importantly, is the next year we're going to have our ASPA conference at Vellore, India. So do save your dates and save it. We're going to have a very special trip to the India, the beautiful country of India. So in September 10th to 12th, 2026.
Dr. Farah, would you like to just talk about a little bit about the pediatric EPM that
Okay,
has
sure.
been happening? I don't think we have a slide for that, but I think it's very
We
important.
do not, but we so for just to let everybody know, when we first started, the first EPM was in July. It was a face-to-face meeting at the Singapore Pain Conference. Was it ASIA? My mind is,
Yes.
I think it was ASIA.
Yes.
It was in July.
ASIA conference in May.
And we had favorable response following that, and with that we've taken in some suggestions and made changes to the slides, and we're offering EPM online now, and that's happening, and I'm checking, I think it's in October.
October
25th.
25th.
Yeah, thank you, Vancy. October 25th, that's the EPM. A prerequisite for the EPM PEDS, though, would be to have done the EPM online version. Because the EPM PEDS will only cover the pediatric component, but we need some other basics that's covered in the EPM adults. I would encourage people to sign up for it, but I would like to I guess remind everybody that it's very basic pediatric management. So it's right down to assessment, talking to children. Do that and then go on and do the EPM trainer course, and then you can actually teach EPM later, and you can run your own EPM PEDS courses. So how would we advertise that link? Perhaps together with the email, would that be possible? The post?
Yes, we can. If you want to send it to the other PPSIG members, the link can be posted in the in the WhatsApp group chat.
Okay, and I'll pass it to one of you then, and then you can pass it to the rest.
Yes.
Awesome.
Yes, we sure can.
And that's EPM PEDS.
All right. Any last words from our speakers? We do thank you very much for all the effort that you have put in, the time that you have put in preparing for your talks, as well as being present here on a Sunday.
Really amazing talks.
Yes, yes. So thank you very much. Let's give our speakers a round of applause. Thank you very much. We do hope to see you again on the second installment of this webinar. Anu, would you just like to give a little teaser on that and then close everything?
So this is going to be continuation of the part one of our webinar. That will be talking about pain in children who are coming with endocrine issues. It could be also dealing with sickle cell crisis. So a little will be touching on hematological conditions. Also Crohn's, ulcerative colitis, functional recurrent abdominal pain. So a lot of interesting topics coming up. So all of you who are all practicing pediatric pain, please stay tuned. We'll definitely send you information about what Dr. Farah mentioned about the EPL and the next webinar. And just one last announcement came on the same day on October 25th, we are having the first ever pediatric pain CME in India. So for all any of the attendees who are participating from India, please do think of registering for this one-day CME which is happening in Bangalore at my institute, Indira Gandhi Institute of Child Health. So we'll definitely send out the links for registering for all the three of them. Yeah. Thank you so much.
Thank you very much, Dr.
Thank you.
Dr. Anand and Dr. Shou. Thank you very much for attending for your presentation today. And to my co-panelists, it's been a pleasure sharing the virtual stage with all of you.
Thank you.
Thank you and have a good day.
Have a good week ahead. Thank you.
Yes, to everyone. Bye. Thank you.
Bye. Bye, everyone.